Hello and welcome to the webinar, Patient-Centered Medical Home, a case study on achieving Level 3 recognition. My name is Melissa Da Silva and I'll be acting as your moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. And I now turn the mic over to our presenter, Anna Gard. Anna?
Welcome, and thank you for participating in today's webinar, Building Patient-Centered Medical Homes with Transdisciplinary Teams, a case study of Hudson River Health Care, presented by Kathi Brieger, the COO of Hudson River Health Care and President of the Association of Clinicians for the Underserved. My name is Anna Gard. I am a family nurse practitioner and the Health Disparities Consultant for the Association of Clinicians for the Underserved. I serve as a consultant to the National Healthcare for the Homeless Council on patient-centered medical home and health information technology. Today's speaker is Kathi Brieger, as I mentioned, Chief Operating Officer of Hudson River Health Care and the President of the ACU. Kathi, as a registered nutritionist, has worked in community health centers for over 25 years, focusing on diabetes, nutrition, and health promotion. She has lectured for the National Institute of Health, National Association of Community Health Centers, and the National Nutrition Summit White House Conference on Hunger. She has served on the New York State Department of Health Diabetes Task Force and the National Center for Farm Worker Health, Breast, and Cervical Cancer Education Project Task Force. She was the lead for Hudson River Healthcare participation in the HRSA Health Disparities Collaboratives in Diabetes, Redesign, and Prevention Prototype. And she has been instrumental in the implementation of the electronic health record, of which they use eClinicalWorks in all 16 sites in 2008. Today's session is an introductory overview of the patient-centered medical home and Hudson River Healthcare's journey towards NCQA Level 3 patient-centered medical home recognition. Hudson River Community Health is a FQHC network of 16 community health centers and mobile services located in New York State's Hudson Valley, serving diverse populations in both rural and urban areas, including homeless, migrant, and public housing communities. Hudson River Community Health provides comprehensive primary, preventive, and behavioral health care throughout a 9-county region to over 65,000 people. I am pleased to welcome Kathi, my colleague, and look forward to having her share her expertise today. Kathi?
I did want to say that I am so happy to be here today. This presentation will go over a lot of the information you'll need to learn about when you're applying for patient-centered medical homes, and hopefully you'll walk away with a sense of what things you may need to look at when you're considering patient-centered medical home certification. I did rely on a lot of our colleagues in the public health realm for a lot of the information that we had as we were applying for medical for the patient-centered medical home, and I believe that at the end of the seminar today, you'll hear about some other resources that you can take advantage of. So, beginning with that, I do want to say that I did get some great slides and help from PCDC, ARC, the Commonwealth Fund, and the Primary Care Collaboratives, as well as the national website for the Healthcare for the Homeless. I think you'll all find great resources on those, and we'll be able to share some more information about that as we go through the presentation. So today, I wanted to begin with looking at what is the history of medical homes. We know that they've really been around for a long time. Since the 1960s, we know that the American Academy of Pediatrics, if you look at the earliest literature, had described these places and the systems of care. We know that the Patient-Centered Primary Care Collaborative that started in 2006, using some of the information from both business world, the IBM, and payers, as well as primary care academies, consumer groups, we're able to really come up with a lot of things that will really help us to learn more about how we can then take on this patient-centered primary care initiative, medical home. So let's look at, this medical home. It's actually not a physical place, which sometimes people say, well, what is a medical home? It's actually a place that looks at patients from their perspective. It's providing comprehensive services that are coordinated. They're also accessible. And for the homeless community or other transient communities, we know that that is really very important. And then it also provides, when we look at a medical home, it's where we're continuously improving through a system-based approach for both quality and patient safety. So I think as I begin to talk about some of the things that you need to have in place, you'll see that, yes, all these things must be met for a medical home. So let's look, why all the buzz about patient-centered medical home? I'm sure you're like me in that every day we get emails, we hear about seminars being presented, all about the patient-centered medical home. Well, what is it all about? Why all the fuss? So let's look at the cost. We know that we're looking at, we know that there's an increased cost of health care around the country, and we're looking, oops, sorry, I'm sorry, that it looks like I went ahead. So we're looking at patient-centered medical home. We know that there's an increase in affordability. We know that in our world, many of the duplicative tests and things that are done can really be prevented in a patient-centered medical home. We also have learned a lot about satisfaction and experience, and this is something I'll talk to you a little bit later about what our experience has been around collecting this information and what we've learned from it. And this really is not just about providers, it's really about the whole healthcare team. The idea of quality being impacted in a positive way. We know that with a patient-centered medical home, we're more able to look at the whole community, able to coordinate care in such a way that it's actually improved. We're also looking at incentives from key payers, including for New York State. We're getting some reimbursement that is really part of the patient-centered medical home. And I think that we're going to find in different states there are different reimbursement mechanisms, which you'll have to be part of your due diligence when you're looking at whether or not you really apply to become a patient-centered medical home. We know that in a lot of the research that's come out, and Bodenheimer is really a great, and Grundy, those are names that you've really heard, and Grumbach, about some of the positive effects on patient care. And you'll see this is just a summary that was developed using all of the places that have done some research. You can see that quality is a strong marker for improvement on all of the areas. And believe it or not, we found this better work environment, having teams. Actually, when we look at the transdisciplinary team, all members of the team, you'll find that it's very interesting that there's actually an improvement in team or staff morale. Reduction in ER and inpatient and hospital costs. All of the studies are showing that this is happening in a patient-centered medical home. And while some of the places out there on the webinar today may not have this information, we've actually started to see this happening from our end, from our health center. Better patient satisfaction and access. One of the things that we looked at, which I'll talk to you about, is the CAP survey. We were able to get more information about how our patients experienced care, and we were able to make changes based on that experience. So from the research, we're seeing that there's really been a great impact, positive impact from the patient-centered medical home interventions. Ann Beal, from when she had been working at the Commonwealth, had published a great research study on what were the racial and ethnic differences in getting medical care when patients were seen in a medical home. And it was amazing that health disparities were leveled out when people were associated with a medical home. So we see that there's not been a lot done with special populations like migrant and seasonal farm workers or homeless, but I can tell you anecdotally from our experience, we have seen a difference in how patients are getting care when it's rendered in a patient-centered medical home and when it's rendered without that kind of structure. We'll go over that in just a minute. So let me just tell you a little bit about the Commonwealth Fund, and I think because I have we have really gotten a lot of information from this initiative, even though we were not part of it. Their research and materials continue to help us look at some of our systems around the patient-centered medical home. So the Commonwealth funded about 60 safety net providers in 4 regions to look at medical home status and what were some of the also leading researchers. They looked at helping to transform these safety net clinics into patient-centered medical homes, and they awarded a grant to Qualis Health of Seattle, and they also partnered with McCall Institute. All of you know Dr. Ed Wagner. If not personally, you'll know his care model. And they actually structured this, NCQA's patient-centered medical home within the context of the planning of the care model. So I think using this information, I find that there's really a lot of great resources that we've been able to use. So let's think of it when we're looking at patient-centered medical home and we look at all the folks that we serve on a daily basis. It really looks at addressing some of the deeper roots of health disparities. We look at what is the economic security of our patient community. We also look at, when we look at working with different members of the healthcare team, educational and career opportunities for both our teams and also the communities that we serve. We look at building trust with our patients, and of course many of us really are a medical home without the official title. I think for many years our patients come to us because they trust us, they feel safe with us, and I think that this really is one of the building blocks of this whole idea of medical home. When you look at all the other things, if we are assisting patients with accessing some economic benefits, whether it's in the form of Medicaid or whether it's a food, helping people get, if there is a food insecurity or housing insecurity, all those things can be helped by our medical home. We also look at building a diverse healthcare workforce. I know that, like us, many of the people out there in the health centers have tried to hire from the communities that they serve, and I think this helps to keep people's focus on the main goal, which is to provide whole person care. Some of our most effective staff members are people who were prior migrant and seasonal farm workers, or they were homeless themselves. I find that those people are really best able to be part of this healthcare team that looks beyond the medical home and really looks at treating the whole person with all parts of their, all parts of their care. We also look at integration, true integration. It's not just about the physical body, oral cavity. It's also about behavioral health. It's about pharmacy, getting medications and getting medications in a way that they can use. If people have no home and no refrigerator, it's pretty hard to have a refrigerated antibiotic. People don't have transportation to the lab to get their lab blood drawn. It's pretty hard to get that done. So I think looking at all of the treatment, aspects of a patient really are critical when we're looking at the medical home and actually looking at a healthcare home. Looking at all services including WIC, maybe outreach and transportation, and then most importantly, I think for the homeless or people who maybe have transient life situations, looking at other community organization and linkages that might help them to lead a better, healthier life. When I think of some of the requirements for the patient-centered medical home that we needed to address, some of the things I'll be spending a little more time on that relate to this program are about self-management, patient involvement, and I think that whole working with partners so that you'll be better able to achieve certification for the patient-centered medical home. I'll be spending more time on that as we go along. So let's look at those standards. What are the 2011 patient-centered medical home standards? We look at enhanced access and continuity of care. We had to do a lot of work around empanelment. And for those of us, you've probably been working on paneling for a long time. That's matching your provider to the patient that they want to, that the patient matches with the provider that they want to see. and that we also, looking at enhanced access, most places are open at least on evening hours, open weekend hours, going to places where people are going to be congregating. Those are the things that we really are all focused on and that are really important. And NCQA wants to see that we are doing that. So if you have a center that's working with a homeless shelter, going with a team on weekends, those things would really be important. The next standard, identifying and managing patient populations. Again, looking at using, if you have electronic health record, a way of using registries, a way of using reports out of your electronic health record that show patients who might be missing critical tests. If you look at the next standard, which is plan and managing care, again, looking at whether or not your patients have gotten all the tests that they need. If they have high blood pressure and they're out of control, how well are we treating and managing to set up services for them? Those are some of the things that they'll be looking at, and looking at kind of reports, which we'll get into in a few minutes, about how you're reporting or showing that you're actually planning or managing care. Providing self-care support and community resources. One of the things that we have continued to do is, we've had to learn how to track or record our self-management and care support to our patients. And also looking at how do we provide self-care and self-management support to patients who may not be able to read, or who may have difficulty understanding, or who may have greatly limited resources. How do you prepare that? And I think that one of our challenges, and one of all of our challenges, is really to always be mindful of looking back at the patient's interest and how do they want to have these things done. How do they want to get information on how to care for themselves? Just as an aside, some of our sites, we have a PDSA happening, or a test cycle. We have flash drives, and patients were asked, we have a small group of patients testing this out, about what kind of information they wanted on this flash drive around self-care and self-management of diabetes. And it was amazing some of the things they came up with that we would never have put on this flash drive. But again, it's about the patient, it's about what they want, and it's about really listening to them, and not just saying that we're listening to them, but it's really about hearing what they're saying about every aspect of their care. And then community resources, linking them with community resources that they feel they need, and in a way that is really supportive. So that standard, we'll talk a little bit about how we might have used some of those resources, but it's a big area, especially with homeless or with migrant and seasonal farm workers. Tracking and coordinating care. This is a biggie. We have spent so much time in developing our systems, honing our systems, and I would say that we're still working on our referrals. And here we are, 2 years. We became NCQA certified for the first time in 2007, and then we passed the last standards in 2009, and we continued to work on this area. So especially with people who are mobile, it becomes very difficult. We've done some things that I'll talk about with a nurse care manager, but more importantly, we're using our patient care partners or our navigators to help make this all happen. We also have some standard tracking workflows using whole teams rather than just single people in a team. So tracking and coordinating care, we all are going to be looking at achieving meaningful use by Q2 2012, which is a whole nother topic which I won't even broach. Okay, measuring, the next standard is measuring and improving performance. One of the things that we use is the CAP survey, and this measures patient experience. And we've had a 2-year track with this, using this and actually learning from it over the last 2 years, but actually using this information to make improvements in our system. Now, when I look at this, I'm going to go over, one of the things is that if we look at this, this is actually a bus. It's not a car. And I think that when I look at transdisciplinary teams, we're using a bus because we need a bus to fit all the team members on it. And when you look at that bus, this is Hudson River, and I'm going to tell you a little bit about what we did. So it's really a journey, and it takes, if this was a true road, you'd see a lot of potholes because there really are a lot of potholes on the way. You want to know how much will this cost? What are some of the things you need to do to really become a patient-centered medical home will really vary on your site. Some of the best tools and support that we got were from fellow health centers that had done this already. We also had worked in a joint effort with a group that actually helped us to look at what did we need to do for each of the standards. What were some of the reports that we needed to have that would allow us to get to qualify for the NCQA standard or to meet the standard. Some of this seems like a daunting task, and when you're by yourself, it may seem like it's impossible. But we had other partners, PCDC, that was really very helpful and had some great materials, and this is actually one of them. And I think that by working together, you're actually more able to succeed, and I think that's what I'm going to encourage you all to do. When you begin this journey, you see that the work of communication to your board, to the patients, really becomes important, because without their support, you really can't have a successful outcome. So I would say that looking at some of the resources that are available on all those places that I mentioned in the very beginning may help you to be able to present your case, keep everyone informed and involved, and really to avoid some of the things that might happen. You might fall off track or go off the road if you don't keep mindful of what the patients are saying and what your board's saying. I also want to say that this is such a changing field and world, and a lot of the standards, things change. Resources are popping up every day. I would urge you to keep track. Do attend some of those seminars. Try to listen and go to the websites that are offering resources to see what may be new out there and what may help you along the way. So when you're looking at, okay, you've made the decision to become a patient-centered medical home. Now the big job is ahead. Who do you need to be part of this? And I want to say that if you look at it, it's a broad-based team. Patients really need to be part of this in some way, or the caregiver of patient. Of course, you see the medical providers, which may be a nurse practitioner, PA, physician. Payments may vary for the reimbursements, and incentives may vary for medical providers, but everybody needs to be on the team so that they're able to understand everything. All your clinical support staff, I've written patient care partner, although you may have patient navigators, you may have other titles that you use, coaches. I include dentists and dental hygienists. While they're not involved with the patient-centered medical home officially, if you have problems with your oral hygiene or oral care or oral health, you're going to have physical problems. So I see them as integral to this whole process. Patient reps are your frontline staff, outreach, community care partners, AmeriCorps, dietitians. All of these folks play a critical role, and I think if you look at a broad-based team, you're going to have more success with your application. So you need to have a core team, though, people who are going to be the cheerleaders. And for those of you who participated in the health disparities, you're going to know that you needed to have someone who was a real central leader to this team. And if you look at that, that person has to be respected and knowledgeable about your whole process, your whole center, or knowledge about your centers. And they're going to need at least 10 hours a week to be involved with this project. Depending on other team members, it may take 4 to 6. I know some weeks we had people who were needed maybe 15 hours at the end, although in the beginning when we started it was probably more like the 4 hours per week. We needed to set up some established times so that everyone would know this is where we were going to do this. We also, we needed operations knowledge for all sites involved. Our health center, Hudson River, actually has 16 established sites, 7, and then the mobile services. it can be a real challenge having standardized practices everywhere. And one of the things that came out of our whole process and application was that we really needed to work on some of our procedures and processes to try to corral some of the cowboys and cowgirls out there. And some of you hopefully know what I'm talking about. But the tips for developing your team, I think, is really looking at, and this slide might not be real clear, we use this slide in training our staff about how important all the different roles are. And basically, I'm sure you have the same kind of system where you have the patient is at the center, and you have everyone who contributes to this care management. And in order to do that, when you're starting on your trek to become a patient-centered medical home, making sure that you communicate with everyone on your team and making sure that everybody knows how everyone else is involved with, whether it's care management, becomes critical. So communication with all team members is really important. I think one of the things that we did when we first started was to actually teach our employees what this whole thing was about, patient-centered medical home. And we found that we need to make sure all members of the team are involved with delivering care and that they know how important their role is. One of the things that I also see is that we know that if we listen to the different team members, we may be able to improve aspects of the care that we had no idea were going wrong. And I think some of our greatest tips were people who were at the front desk. And so I just wanted to put a plug in that it's not just the clinical folks that are involved. This is definitely an effort that involves everyone. So I also think in this situation it's important to look at external partners. In gathering information about patient experience, we found that sometimes we have to look at if people are living in a shelter. We might not be able to have a home address, but they're using sometimes it's a day program that they're going to where they have their mail delivered to. Getting patient surveys done in a way that can meet with a transient population is really going to require some thinking. If you have a relationship with a meal program, or if you have another, the street outreach workers or homeless shelters, or in one of our counties we have a mental health association where a lot of people get their mail, that might be a partnership that you form that can help you to meet some of the requirements for the patient-centered medical home. Specifically, I think of the one about care coordination and the CAPS, which is the patient experience survey. I wanted to go over and just show you some of the things that you'll see when you actually go to begin your process with the patient-centered medical home application. There are about 13 slides here that I have included, but I'm not going to spend a lot of time on them because you will see them. I really want to spend more time on some of the troubleshooting that you'll experience and some of the questions that I think you will have around, how do you meet these standards? But I did want you to see some of the things that you'll be aware of. You'll be taking an assessment of your readiness, and I think it's really useful because we had each of our sites do this assessment to see how well they actually were able to do. And we found that even though we were the same health center, that some sites had some issues around certain topics that not all health centers under our direction were having. So we had to really look at standardizing processes, and this tool or the assessment actually helped us. So we looked at, how is it scored, and if you look at each of the elements, you'll be asked to provide, you'll be asked to provide evidence that you're meeting them, either in, I would say some screenshots. If you use an electronic health record, we are asked to show how do we monitor access, do we track, when we looked at access, I'm sorry, here goes my arrows. When you look at some of the access, we had a system where we reported how many days patients had to wait to get in, and we've been doing this for over 10 years. We've been using some of the standard tools that were counting the day to the third available appointment, and we use this to report to our board, our site so everybody is aware of it. When we submitted this to NCQA, we actually had to explain how we use this, because this, I think, is a standard tool, but we actually had to show this. And I think when you have a question, you could also ask the folks at NCQA for clarification, and that's what we did around access. But for each of these measures, you'll have to show how you're meeting those standards. In order to meet level 1, 2, or 3, you'll have to score a certain number of points. We had met level 3. We earned between the 75 and 100 points. And if you look at it, each of them have must-pass elements that get stricter with the level. So some of you may say, I can't meet level 3, but I can meet level 1 or 2. You'll notice that the level, that it's a little less difficult to reach from 1 to 2, but from 2 to 3 there may be a bigger jump. So you may assess that whether or not you feel you could do it after you look at the website and do your own self-assessment. So looking at this, there's a tab for instructions. You'll see summaries. You'll see all the standards that are color-coded. It looks like a maze, but I think if you look at this for a little bit, you'll be able to see how do you use this tool. Now, my slide is not really clear, but again, I'm not going to spend a lot of time here. It's just that you'll see that there's a 4-tiered rating system, and you'll be looking at existing documentation and also what are some of your next steps. This is a great planning tool for you, as well as when you're looking at your assessment, you'll be looking at what is the effort needed to get to some of these practices that you'll need for PCMH certification. Again, I'm not going to spend a lot of time on this, but you'll see lots of columns, and each of the categories will be requiring you to either look at policies that you have, examples of how you track things. What we found was that some of our policies were not as well defined, especially when we looked at some of our reporting systems. How did we report back to our staff? How did we use the reports? We found that we had to make some changes, and I think that was why it was so helpful to have other partners that we could share practices with. And if one of our sister health centers was able to have a good policy on care management, we were able to share with each other. So let's look at some of the experts that we needed, some of our team members who needed to be called in. When we had an issue with one of the procedures, we would actually call in our team members to see how do we actually improve that. We looked at some of our practices that didn't have any policy, and we had to develop one and then work on making sure it was instituted. And when I go through these, I'm just going to go through them quickly. When we looked at some of our electronic health record too, our format was not as well defined as we thought. Sometimes it's not enough to say that a screenshot comes up or a flag comes up on the medical record, on the electronic medical record. You have to actually show how you can get a report on that topic, so that if it tells you that all patients who need a flu immunization, that you'll get a red flag that pops up. They want to see that your EMR is actually able to give you a report on all those patients who need that. So those are some things that you'll see as you go along. Let me move to some of the things that we really, I think, struggled with, because I think that might help you to understand, where some of the time is really going to be taken up. And I have just about 5 more minutes, I think, so, or maybe I guess 10 more minutes. When we look at referrals and transitions of care, this becomes very difficult to track when you have patients who have a stable home situation. So add on to that someone who's living in a shelter or someone who might be moving from place to place. It becomes more of a challenge. So really making sure that you have people doing great outreach, keeping track of new address changes, and asking patients if there's any place that they can be sure to get mail. Even if they can't live there, they could be sure to be contacted is really important. Some of the things that we found helpful is we have an individual, an ID card for our patients, and they really like this. It actually is part of our, what we call our Care Solutions program, which helps people to assess, helps patients to see where they might be eligible for different programs, and they use this when they end up in the hospital or when they're going maybe to another place for care. This card, I know that there may be some sites have developed these little wallet bags which hang around the neck. Years ago, the National Health Care for the Homeless used to have them for the diabetes tracking, and I'm not sure if that's still available, but those kind of things are really helpful. They keep these cards in place so that people can not lose their materials. So I think also when a person has a lab results, having outreach workers know where to reach those people becomes even more important in this kind of transient group. When I look at one of the things that Dr. Wagner had done for this collaborative, for the Commonwealth Collaborative, was to look at referrals in terms of the Institute of Medicine standards of timely, safe care, effective care, patient-centered. And I really liked kind of that format because it looks at how difficult it is. You want to make sure that everything is timely so that patients are not waiting for weeks to get their results, and that safety, patient safety in getting these referrals is really a primary concern, and making sure that we're able to work with partners to get, sometimes with the Mental Health Association or other partners, to make sure that the information they get have timely and safe information. There's also looking at things from a patient's perspective. What, how can we work with them on referrals and get, make sure that they're able to get that information and efficiently, also the efficient care, and also care that's equitable. We want to see the same results for hypertension control and glucose control for someone who's homeless as compared to someone who has a stable home situation. So those are all things that I think, if you look at that reference, it's free and it's really a great resource. So how do we get successful referrals and transitions? We found that making sure that we are accountable as the patient-centered medical home. We make sure that we provide patient support. If sometimes it's transportation, getting a voucher, working with a community group to get a ride for patients who may need help. Also building relationships and agreements among other providers. Sometimes we assume that people in private practice don't have the same compassion or care, but really building those personal relationships with other providers and organizations are really important. One of the things we found, we're saying developing connectivity via the electronic world or another pathway that will allow people to send information, and that's providers. One of the things we found when we went to the community were that we found out that even though we were sending our patients to these providers, that when they tried to send back a report at one of our sites, our fax machine was not working or getting a busy signal. When we found that out, we were able to address it, but had we not gone and actually talked to them face to face, it might have gone on for who knows when and who knows for how long. So I think actually having conversations with people the old-fashioned way is actually a great thing, and it helps to develop successful referral systems. I really want to make a push on health literacy, and I want to say that when you evaluate all materials, when you look at all the materials, we really have to make sure that they're understandable, and it's not just for people who can read. I mean, this is having photographs or using things that it really makes sense to people. We also want to make sure that people know how to use their medications and treatments. What we found too is one of the things that when people are discharged from the hospital, sometimes they're given information that makes no sense at all, and sometimes they're given medications that, while they may be in the same class of medications as what they were taking on the outside, that they've been changed, and people don't understand that they have to discontinue the one that their doctor was using, that their provider was using in the health center, because the one in the hospital may be a better one. It actually is really important that you have this system in place so that you're really sure that people are understanding what they're supposed to take, in medication especially. So let me ask, the other thing, let me see, with having patients help you review your materials may be one of the best things ever. I want to give it, actually there are two stories that I want to talk about. We had, at one of our sites, which is a large homeless site, we had a patient who had end-stage renal disease, had visual disturbances, really had a very hard time with, he really depended on all his meals at one of the food programs. We had to really use all members of the team to help this patient. We're still struggling, so I'm not going to make this sound like things have really been completely improved, but what we found was that the man was not eligible for some of the programs because of his immigration status. We had to negotiate with some of our community partners to get medication money. He's actually doing much better. His hemoglobin A1C is down to, I believe on the last count it was about 8, which is a lot better than it had been. We've gotten some standard. We worked with a local hospital to get him help. I also had another story just yesterday. We had a patient who he came to us with a hemoglobin A1C of over 11, and he had been living with his mother. His mother died, and he was about 53. He was about 53, and after his mother died, he became homeless, lost his job, and it kind of escalated into a big kind of a mess. And he was living at the shelter and not really eating regularly, and so we helped to get him linked with a lot of support. We worked with him through the Mental Health Association. We were able to get the housing for him. We were able to get him established with some regular medication assistance, and now his hemoglobin A1C is actually between 7 and 8, so we're really seeing some significant improvements. And so, it can work. Having this integrated system takes sometimes a lot of effort, but it's well worth it because we feel we are really saving people's lives and actually making the quality of their life a lot better. So I just wanted to point out this is an ARC's website, and I like this resource center. It's another place where you can get help. And I wanted to also add this patient-centered medical home website. One of the things we found was that if our staff did not understand what this was all about, patient-centered medical home, we had really, we would have missed the mark. And I think that I love to use this video because it's a simple 4-minute video that's in English or Spanish. I don't think we have enough time to see this today, but I did include this in my slides because I think that we are using this to actually go back and show it to all of our staff during trainings that we have. When we talk about teamwork and coordination, we play this video because it really helps to put in very simple terms what the patient-centered medical home is all about. So I'd encourage you just to take a look at it when you have some time. I did want to look at, some of the things that I'm getting some messages that John from the Homeless Association is saying that they do believe that they still have card holders, so that might be something that we can look into later. And we have a number of questions about the referrals, which we'll go over too. And I think I'm going to turn this over to Anna.
Thank you very much, Kathi, and that ends our formal presentation. But before taking your questions, I'd like to call your attention to the slide that you have in front of you, and it's a resource slide which provides context and links to additional patient-centered medical home materials and toolkits. These resources and additional materials will be posted on the National Healthcare for the Homeless Council website, and the PowerPoint presentation and replay of this webinar will be linked from the Council homepage. To just give you a brief overview of the Patient-Centered Medical Home Resource Catalog, that catalog is divided into 3 sections. One provides patient-centered medical home resources, including websites and newsletters that will provide continuous updates about patient-centered medical home initiatives, including best practice examples and payment reform models. The second section lists several patient-centered medical home practice assessment tools, many of which you saw quick screenshots that Kathi showed, and will assist you in engaging your organization in readiness to implement the patient-centered medical home model in your clinical practice. And then the third section of that resource catalog lists organizations that currently have a formal patient-centered medical home recognition or certification process. As I know there was a question that came in about the NCQA and Joint Commission requirements, and we'll answer that during the question and answer session. The second resource is the 9 Steps to NCQA Recognition, and that we drafted with the help of some consultants, including Kathi Brieger, about what steps you need to take in order to move through this process. And I just wanted to highlight that Step 3 talks about HRSA's initiative, which encourages its grantees, the 330H grantees, to apply for NCQA recognition, and will cover the costs of the NCQA survey tools and recognition fees. However, the application deadline for this support is September 30th, 2011. That doesn't mean you need to be ready to start the process. This is just an application for their support. So if your organization is considering it and in the planning phases, you need to just apply before September 30th, 2011. You can look for the website and the contact information again in this 9 Steps to NCQA Recognition. And so they are the resources specific to that, to patient-centered medical home and what we've covered today. And now we're going to open it up to any questions, and I will hand this over to Melissa.
Thank you, Anna. Thank you, Kathi. I guess we'll start with the question, how do you prove that referrals are tracked? So I'll let you respond. I turn the mic over to you, Kathi.
So how we did it, this was actually a work in progress. We started with looking at our electronic health record. We were able to do those patients who had referrals that were resolved or reviewed were checked, and that was in structured data, which allowed us to get a report. We found that we had a problem with our referrals because we weren't resolving all of those. We had to match our policy, which said that we had 3 different standards: an urgent, a stat, and a routine referral. And those we had to establish different guidelines for how long it would take to have those resolved. And then we had to develop a report based on our electronic health record that would allow us to track whether we had addressed those in the time frames that we did. So it's based on a report in our electronic health record. I will tell you that it's been a continuous I would say bear to always deal with this, but we did actually have to have the follow-up report, and we use that regularly. Hope that answers your question.
Thank you, Kathi. The next 2 questions, actually, they're related, goes to Anna from Francis. What is the difference between NCQA and Joint Commission requirements/process for medical home recognition? And then from Barbara, thank you for your question, which is preferred by CMS and or HRSA, NCQA or Joint Commission? I turn the mic over to Anna.
Thank you. I saw that question earlier, and in fact, Kathi Brieger and I discussed this before we put together this webinar because there has been a healthy dialogue about this issue on the healthcare community's listserv, and in fact, I am going to paraphrase Kathy's CEO of Hudson River Health Care, Paul Kay, because he wrote a lengthy response about this. JCHO has historically been excellent at evaluating the fundamentals of clinical quality: accuracy of lab testing, infection control, patient safety, clinical competence, and robust performance improvement. All of these are really necessary in providing high quality care, but there's no point in being a medical home with lousy plumbing and heating and a shaky foundation. And as I said, I'm stealing that quote from Paul. But NCQA has concentrated more on issues of access to care, patient-centeredness, care coordination, as well as population health management. So NCQA is really useful for evaluating your processes as a health center, things like appointment making, triage, follow-up, self-management, support, care coordination. It also has really closely aligned its newest 2011 standards with the meaningful use requirements, and those are the meaningful use of electronic health record incentives, which in itself will be a whole other webinar. But in order to be eligible for the meaningful use financial incentives when adopting and implementing your electronic health record, once you establish meaningful use, you're really 50% of the way towards NCQA patient-centered medical home recognition. So because these two incentives and recognition processes are so closely aligned, the third-party payers and many of the demonstration projects are really focused on incentives and reimbursements for the NCQA recognition process. And in fact, I'm not really aware of any demonstration processes that are reimbursing for the JCHO accreditation. However, again, I want to refer you back to the Patient-Centered Medical Home Resource Catalog that was on the resource slide, because in Section 3 of that it does outline the different organizations. There are a few other that are just starting into patient-centered medical home recognition or credentialing. Some are not completed yet, but all the websites and contact information are located in the resource catalog. So I hope that answers your question.
Thank you, Anna. The next question comes from Sharon Rapport. Sharon, first of all, we will respond to this question also by email, because we have a lot of information we can send to you that possibly Kathi will not be able to address right now. But I am going to ask Kathi if she wouldn't mind beginning to address your question, which is, could you address the importance of connecting homeless people to housing to improve health status? I turn the mic over to Kathi.
Well, this is such a critical question, and I think it's really at the very foundation of all that we believe in. Hudson River Health Care actually has committed over 15 years ago to establish a kind of a branch of our agency called Housing Preservation. We own 8 apartments for people who are either had been at risk of homelessness or who were homeless, and we also do programs every week for people who are at risk of being homeless, and work with them to make sure that people are able to get homes or stay in their homes. We find that if a person does not have a home, a safe place to go to, we can't even begin to talk about health status. And I think if we can all look at this as a human right, a place to live, a safe place to live, it's really where we should all begin. And I think that looking at the medical home, if we have our intention here at Hudson River, like many of you, is to look at the whole person, and to say, if we can work with getting them stable housing, it's going to be really fundamental to improving their health status. So those are just my thoughts, and we have made that commitment. We've had this housing preservation company for a long time, and it's been a great asset.
Thank you, presenters. Thank you so much, Anna Gard and Kathi Brieger. Please, participants, if you have any other questions about this topic or any questions related to healthcare and homelessness, please contact us at the Council. Visit our website at www.nhchc, and of course, please contact us through our TA request form if you've got any specific requests about TA and training. If you'd like more information about this topic, please call us and or email us. All of our contact information is available on the website. And I would like to draw your attention again to the slides on more information on this topic and upcoming events at the Council, including our Detroit Regional Training, September 19th and 20th in Detroit, Michigan, and upcoming webinars on motivational interviewing and the HCH and Community Mental Health Provider Partnership, September 22nd. Again, thank you presenters and thank you participants for joining us on this webinar, Patient-Centered Medical Home, a case study on achieving Level 3 recognition. And do not hesitate to contact us with any requests for information. Thank you again. Have a great day.